Okay, so it's time for us to start this webinar. Just like to welcome everyone to this from around the globe. It's very exciting to be here, and we are grateful to WABIP, Michael Mendoza, and Ambu for asking us to share with you some thoughts on the clinical role of single-use bronchoscopy. It's my great pleasure and honor to introduce co-attendees and co-hosts. Firstly, Dr. Sonali Sethi, Director of Interventional Pulmonology at the Cleveland Clinic in the USA, and Assistant Professor Jonathan Kerman, who is Director of Interventional Pulmonology at the Medical College of Wisconsin in the US. So it's a real pleasure to have you both here. What we intend to do is to go through three talks. I'm just going to share my screen now, and essentially they will be 25-minute talks, and then we'll move on right at the end to the question and answer session. Hopefully that'll be an interesting forum for discussion, and we would encourage all of you to speak or put in the chat any questions, any comments, any controversies that you'd like to raise. That'll make this the most useful of webinars. So what we intend to do is talk about the clinical role of single-use bronchoscopy in the ICU and its impact on clinical workflow and guidelines. And then we'll move on to the bronchoscopy suite and interventional pulmonology, looking at its clinical value and advantages of bringing single-use bronchoscopy into that space. And then concluding with cost and an overview of cost-related aspects of single-use and reusable bronchoscopy, and indeed the organizational impacts. So without further ado, I'm going to talk about single-use bronchoscopy in the ICU, current and future clinical impact. I'm a respiratory and critical care physician in London in the United Kingdom. I'm also an interventional bronchoscopist, and I work half-time in the bronch suite as well as in the ICU. Here are my declarations, research grants, advisory board meetings, and speaker honoraria and educational grants. However, I have no affiliations to any single industry or company. I'm going to start with history. It's always a good place to start. So we're all familiar in this forum with Gustav Killian in 1894 and the esophagoscope, through which he was able to retrieve a foreign body from the larynx and publish that as a case report, which really initiated the visualization of the airway proper that was then developed some years later through the use of the light source and suction channels to the rigid bronchoscope with Chevalier-Jackson. And of course, there were further developments until one might consider this the origins of modern flexible bronchoscopy, and Shikedo Ikeda with the Nakita company was able to develop this device and then take it and promote it as something worthwhile. Interestingly, in terms of history of the bronchoscopy in the intensive care unit, he actually took it to the American Thoracic Society surgical conference, and he was identified by Sackner, who persuaded him to provide him with one of these flexible scopes, and Sackner used it in his ICU, and then published a whole range of case reports and series demonstrating its use in ability to intubate patients in the early 70s, indeed for patients with sleep apnea with vulnerable airways, and also developing the nasal route for bronchoscopy. And in Chest in 1972, he published those applications of bronchofibroscopy. And then it was in the 1980s that the first charge coupled device was developed by Pentax, and effectively the first videoscope came into use. Ambu were the first company to produce a single-use bronchoscope in 2009, the A-Scope 1. And that has developed, as we will talk about later on, now into the A-Scope 5 high definition, the latest generation of technology. When we talk about bronchoscopy in the ICU setting, and of course beyond that, then it's important for us to consider needs and responsibilities, and we all wear different hats. And if I just allude to some of those different responsibilities. So as a clinician, what do I want from the bronchoscopy that I'm asked to do? I need to make sure that my patient indications are clinically relevant. I want to make sure that this is going to be as safe as possible. As a bronchoscopist, I want the equipment to work such that I can perform the procedure technically well in as quick a time as is possible, but to achieve the goal that I'm intending. If I put my clinical director's hat on, of course I want those things, but I want to make sure that there's equity of access, equity of opportunity, and not wastage unnecessarily. And then if we think about our roles as educators, we want to try and transfer the skills and competencies that we have built up to get minimum standards and hopefully excellence in the workplace, and reduce that variability that can lead to error and poor outcomes as we aim for the best outcomes for all of our patients. But equally, if I put my research hat on, I, like anyone else, wants to I want to have the new technologies available to me. I want to test them out. I want to see how robust that evidence is. And I want to see ultimately where it's going to fit in my workplace and then in others. Now, as opinion leaders, we have a further responsibility. We need to understand where this technology is going to fit in the broader scheme of things. And we have to understand things like high income, middle and low income countries. We have to ensure that wastage is kept to a minimum, but also that other ideals like sustainability and so on are considered. But if I take it back now to the clinical level and the clinician level, I'm just going to talk you through some of the things that we all know, but in the ICU setting, what are the indications for bronchoscopy? And I've numbered them 1 to 9, and this is not an exclusive list, but essentially infection identification and particularly ventilator-associated pneumonia. We've used that bronchoscopy increasingly, although there's very limited evidence as to its definite benefit in that regard. What we do know is that it can reduce unnecessary antibiotic usage by taking distal samples. And interestingly, during the COVID period, where broadly speaking, 40 or 50% of patients that were sampled using new technologies like PCR were found to have secondary bacterial infections, depending on which studies one looks at. And then, of course, therapeutic lavage for collapsed airways. And if it's done properly, then it can have both a physiological, clinical, of course, and radiological effect. And then there are slightly less common adverse events, such as tracheal perforations, but using it as a problem-solving tool can be very important in these settings, or indeed tracheal flaps following tracheostomy with acute airway obstruction thereafter. Foreign body removal, number 5, again picked up and one is aware of the possibility of that, then the bronchoscopy is an essential tool in that setting, as it is for difficult airways and planned or even emergency procedures where the purpose is to provide a definitive airway, even in complicated scenarios. And there are less common but equally important indications, such as persistent air leaks and the use of expiratory-only valves that are part of bronchoscopic lung volume reduction, but have a role to play in persistent air leaks in the ventilated patient. And of course, percutaneous tracheostomy for direct visualization of the airway to try and minimize damage or risk of damage to the posterior wall, and to ensure appropriate positioning of this definitive airway. And then, of course, Burns inhalation injury as a niche esoteric indication to be able to grade the injury that we know portends a worse outcome in cutaneous burns. So there are all those indications for which bronchoscopy in the ICU setting is important. And here listed, perhaps in order of relevance and frequency, are the airway management in the anesthetic room, and of course, confirmation of the endotracheal tube positions, assessing the mucosa, source of bleeding, sampling, segmental collapse, and fistulae. And then therapy, of course, the use of therapeutic lavage with adjuncts, tracheostomy, foreign bodies, airway hemorrhage, which is another rare but very important and often life-threatening indication for appropriate skilled bronchoscopy in this particular setting, together with less common but sometimes important interventions such as stent placements. And then if we think of what has happened in terms of the transition from the traditional video stack reusable bronchoscopes, it would seem there's been a natural transition to reusable single-use scopes over perhaps 5 to 7 years, in fact. And here just some illustrations of the previous in the top panels, reusable scopes for intubating patients nasally, or in very sick patients, or even through non-invasive ventilation, and now to the transition where, in fact, having the reusable scope and monitor at the bedside, or indeed in the operating theatre, makes it accessible, portable, and provides one with a range of different options in these settings. So why has this happened is one of the questions. Well, convenience is the most obvious explanation for it. The fact that you've got a carryable, portable, plug-and-play system that provides adequate optics. And I say adequate because that at times has been a question mark. And it also depends on what you're expecting. And if someone is doing a bronchoscopy in an ICU and they're not really that interested in where the problem is, but merely to try and clear the secretions, well, I would suggest that that's a missing opportunity. In fact, and that we'll come to later on as the opportunity to use single-use scopes to try and drive education and improved training. But we also know that with improving technology, higher definition is going to make this much easier. And then the use of, the question is single-use bronchoscopy for all procedures in the ICU. One might expect so, but you have to question more complex diagnostics and therapeutic needs. Here, an example, someone with a post-tracheostomy acute critical stenosis, cicatricial stenosis of the airway, where a stack system wasn't available at the time. And so one had to compromise and use an ambuscope, as it happened, with serial dilators to actually provide a catastrophe. And at the head end of the bed is the thoracic surgeon in case of a need to open the chest. So you know, it has been used. That's not to say that it should be used. What about airway hemorrhage? And in this case, on an ECMO patient, that's the reason he remained alive. Severe catastrophic bleeding, organization of clot, and the use of cryo extraction to try, together with conventional means of therapeutic lavage, DNAs to try and provide some meaningful aeration of the lungs. Can it be done through current single-use bronchoscopes? Yes. Should it? That's a question for us to discuss. And indeed, as a problem-solving tool where you've got uncertain diagnoses and monitoring, in this case, a very sick patient immunocompromised with S.r.l and HLH, who developed work of breathing problems, re-intubated, and was found to have a profound pseudomembranous ulcerative tracheobronchitis. You can see here this was a reusable conventional video stack system, but then subsequently with the newer monitors for the single-use scopes, we were able to provide adequate enough serial monitoring. Here, for example, again, a rare condition, tracheobronchopathia osteochondroplastica, in a patient who was on ECMO, who was thought to have severe asthma. Once you've seen it, you'll never forget it, and then you know what the diagnosis is. Here we were using a conventional reusable scope, and this wouldn't have perhaps provided us with adequacy at the time, and with the quality of single-use scopes and monitors that we had available. However, that may well be different now. And here, of course, as alluded to, persistent air leaks, we know that balloon isolation and expiratory-only valves can be very effective. This is not something that is done with single-use bronchoscopes, but it raises the question and the opportunities that are available as the technology develops. If I now switch tack slightly to what the projected development of single-use bronchoscopy is going to be. Well, if you look at this this projection from the US over time, you can see that it's an estimated $2.5 billion industry by 2025, with increasing amounts of clinic, hospital use, and diagnostic center use. Why? Well, if one considers clinical demand drivers, there's an increase in COPD here on the bottom right, third leading cause of death worldwide and increasing, particularly as smoking in the middle and lower income countries becomes on the rise again. If we look at lung cancer, again, lung cancer here is the fifth commonest cause of death globally. It is increasing. And then if we look at the ICU specifically and aging populations, and here I've taken one example of a trend upwards in the percentage of ICU admissions as an increasing aging population starts to knock on the door of the critical care departments. So all of those are going to increase the demand for airway assessments. And these data are from AMBU, which I'm grateful. They show Q1 and Q2 in red or deep pink, and you can see that there's a gradual increase. If you 2020 was, of course, a slightly anomalous year. 2020 and 21 as a result of the COVID effect, but you can see the gradual trend upwards here. This is data for the A-scope broncho worldwide sales, over 1 million worldwide sales, and in fact the NHS safety stocks led to shortages because of huge demand. But what this doesn't tell us is, was this because of more cases? Or was this because the inability to use reusable scopes less? Or was it a transition from reusable scopes to single-use fiber optic bronchoscopy sped up by COVID? And I think more granular data would be helpful in this regard, particularly in the context of high, middle, and low-income countries. And of course, we have to think about quality of life data as well, not just growth trends in the market value. Because remember here, if these are single-use scopes, so they're used once and they should be thrown away. They're not single-patient scopes, but that in itself could lead to questions. Yeah.
Yes. Dr. Singh, so I'm very sorry, but there are a lot of attendees wanting you to have the presentation slides in full screen.
Okay, I can do
that.
That. Possible? Sure. And let's just do
Thank you so much. Sorry to interrupt.
No, that's fine.
So sorry. Thank you.
Okay. Michael, does that work?
A lot better, a lot better. Thank you so much.
Okay. So if we look at the expansive industry R&D to engage that potential opportunity, you can see that there is an ever-increasing list of industry companies who are using this technology and filling the marketplace, and that's leading to excellent competition and no doubt driving the speed and technology. And there are a number of different quality factors in regards to the bronchoscope production that are becoming increasingly beneficial to the end user. Now, if we look at the single-use potential advantages over reusable scopes in bringing new technology to the clinic, well, this is about the innovation cycles. And again, this is data from Ambu that have been provided. If we look at progress from 2009, when this AScope 1, the developed 2011, and then through to 3 in 2013, the 4 in 2017, and now we move to the 5. That's a rapid changeover in development, as opposed to, broadly speaking, the reusable product life cycle of 5 to 7 years for the reusable scopes, although that may well be changing. But nevertheless, that does suggest that technology is advancing quickly, no doubt as a result of high output, low manufacturing costs. But it also raises the question, is this indeed too quick for healthcare systems that are, broadly speaking, a little more cumbersome in taking on technologies and certainly moving to the next generation of technologies? And so the question there is, how does one control that? And are these new technologies all necessary in, for instance, the ICU setting? If we stay on the theme of these drivers to single-use bronchoscopy, and here I've highlighted 5 areas. Now, infection prevention and control clearly has been prime and foremost in the COVID period. But also there's been increasing identification, particularly from the US, the FDA, and a number of organizations, endoscopy organizations, of picking up endoscope contamination and indeed secondary infection, cross-contamination and patient infections that have been identified. Yes, they're very low, less than 1%. However, they can cause significant impact. And as a result of this and these attributable infections, there is move to regulate, and the recommendations are slowly coming out to try and improve the reprocessing systems and reusable scopes, but also to introduce single-use scopes in those domains, particularly where there's a higher risk of infection, or indeed where there are pathway flow problems that could be sped up. And no doubt we'll hear more about that in the regulatory side of things. The utility side of things is clearly obvious: the convenience, the portability, the accessibility. Although there are studies that suggest that the sturdiness of the single-use scopes is still not quite of the reusable scopes in certain settings. If we then move across to technology and innovation, the flexibility of being able to develop newer and better technologies to get them closer to the optics of the reusable scope systems, compatibility such that plug and play for the different types of scopes, irrespective of which organ they're being utilized for, is very important. And the tools that are becoming available, that are already available for reusable scopes in the bronch suite, now becoming available in other areas in the single-use scopes. I've put in grey connectivity and AI. Connectivity, whilst it's appreciated that it's absolutely crucial to be able to have images sent to a repository, either such as DICOM or PACS images, we're not there yet, and that's going to be the next big, I think, technological advance. And then, of course, where does artificial intelligence help us with these new technologies? Finally, at the bottom here, the economics, I put asterisks around costs because that's something that hopefully Jonathan is going to sort of allude more to, and that'll be very interesting to hear about. Sustainability, of course, and that's another discussion point that we might bring up in the forum later on. In terms of some of these regulatory development drivers, these allude to the US and the United Kingdom specifically. July 2013, the National Institute for Clinical Excellence promoted the adoption of the A-scope broncho. Remember, this is a body that is independent of companies, asks experts and opinion leaders to look at the evidence and try and make a cost analysis of whether or not a new device or a new therapy is appropriate to bring to the NHS. It recommended, continued to recommend it in 2020, and the Anaesthetic Association of Great Britain and Ireland highlighted the single-use costs and safety benefits in 2020. Suggesting also that bronchoscopes should be used in COVID patients, which became almost de rigueur whenever they were used. And then in 2021, the FDA recommended single-use bronchoscopes for patients at increased risk of infection spread, as you just heard about. And indeed, in April 2022, there was a safety letter following an urgent recall of a reusable bronchoscope and rhinolaryngoscope due to inadequate reprocessing methods. Again, raising the relevance of single-use bronchoscopy. If we come now to the evidence for single-use versus reusable bronchoscopes, I think this is good quality evidence light, and I will merely highlight a few papers that are relevant to the discussion, but in no way do they suggest in any definitive form one being better than the other. This is a nice review article by Septimu Mergu's group. Essentially, single-use scopes and reuse can provide a shorter time to commence procedures. This was in ICU patients, a small cohort. They were found to be low risk to healthcare worker in the ICU setting during COVID in 47 bronchoscopists in that setting. If we look at their use, and they seem to be comparable for intubation and use in the ICU from this multi-center randomized study, and they looked at a number of different factors like safety, like time for procedure, like following infection risks, etc. If we look at their use in COVID-19, and I'll come to that in a slide or two, they were recommended for use in the ICU. It was suggested to avoid unless necessary, and we, like others and institutional bodies, produced evidence and guidance based on oftentimes practical common sense. If we looked at percutaneous tracheostomy, they, in terms of quality, they're equivalent, but there may well be cost savings, and importantly, it reduces the risk of damage to the reusable scopes. Slim scopes for nasal intubation simulation seem to be at least as effective as reusable scopes, and there's been some bench testing for suction capabilities between the Boston and the Ambu scopes, and again, that drive to further development is ongoing. I mentioned COVID-19. This is in the non-ICU setting, and broadly speaking, different groups have come up with very similar advice that, as we're now all aware of, that only urgent or emergent cases should have been done with full PPE, and ideally in negative pressure rooms to try and reduce the risks to healthcare workers of this aerosol generation and very high risk procedures. That said, in the ICU setting, and I speak from personal experience of looking after hundreds of patients, as no doubt all of you have as well, in that first wave when we weren't using heat humidifiers for the circuits because of concerns regarding aerosolization. I saw a huge number of secretion load desaturations, particularly on proning patients that required emergency bronchoscopy. And we, like others, were keen to try and promote the idea of using the bronchoscope as they were always used in those safe settings, and producing guidance on how to mitigate aerosolization by videos and publications. If we now sort of move to the final couple of 2 or 3 slides, the idea about ongoing clinical research, training and education in ICU bronchoscopy and competencies. What emerged from COVID was this concern about sampling, both the efficiency of sampling, but also the safety of sampling. And for the longest time, we have not used adequate personal protection at the bedside, nor have we scrutinized our practice of sampling. And this has allowed us to start to do some studies. This one that we're running is the S.r.l study, looking at safety and efficiency of a particular closed system sampling device against standard sampling. And this is the first step to try and develop and understand variation in practice, and perhaps through that improve practice and good practice. And through education programs, ours like many others, where we're trying to improve skills, but not just skills, to improve competencies and use of single-use scopes together with reusable scopes for the standardization of training through frequent skills and education, such that we can get ICU bronchoscopy in trainees to the level that occurs with fellowships that many of us have gone through in the bronchoscopy suite. So in summary, single-use fiber optic bronchoscopy is an exponential growth period currently, and it's over 50% of visualization sales are in the ICU anesthetic sector. There are a number of factors that are driving its adoption: the convenience, portability, improved quality. The COVID impact has been significant, and of course regulatory concerns around infection of reprocessing techniques rather than specifically the reusable scopes themselves. We have to consider economics and sustainability. Technological advances are quick. They're approaching reusable scopes for acceptability. Diagnostics and increasingly therapeutic options are available even in the ICU setting. So we're getting closer to that reusable scope offering. But adoption almost seems to be ahead of good quality research. And one of our responsibilities is going to be to regulate and provide good practice guidelines. Where should these be used, in what context, and when should the reusable scopes be used? But there are opportunities for research, education, training to mirror pulmonary programs. And as we embrace the revolution that we're in now, we have to remember that technology, as has been said, is neither good or bad. It's what you do with it that makes the difference. And we have a responsibility both to ensure that it is economically feasible and sensible, that our patients, as examples of society, benefit, but we as healthcare providers benefit together with our partnerships with industry, and of course the sustainable footprint that still needs a lot of work. Because remember, to me, it's somewhat disconcerting to have to throw away a single-use scope after one use, although we have to do it, and yet we don't have a disposable, dissolvable scope, which I hope will be something in the future, and recognizing that there will be coexistence of single and reusable scope technologies. With that, I thank you, and I look forward to discussing hopefully some of the points that I've raised from this later on.